There you go.
Okay. So we are meeting to discuss the synopsis of the two papers. You had one on the lumbar puncture, and I did the one on the eustachian, using the natural orifice of the eustachian tube to be able to locate any tumors or any disease and visually see behind the middle ear without having to lift the eardrum. So these are the two the two papers that each one of us chose. So I read through your paper, and I was actually like 75% in the middle of reading through it when we started here. So from what I've seen so far, it seems to be a very interesting project. There are a few things I'm wondering. It was speaking about the simulation into the simulating the bones with metal, and it showed the region of the spinal cord. However, are these ultrasonic waves gonna be safe to be used anywhere in the body? So did the article speak about where if there are any limitations where it can be used, where it cannot be used? I didn't know about that. So this was one question I had.
So the limitations shown in the paper were that it does a very good job at mapping once the needle is inside of the skin throughout the layers. It does a very good job at mapping where it actually is. However, once it is inside and you have moved the angle to avoid any obstacles, then they need to do they use some type of algorithm. They call it let me share my screen here. You see my screen?
Yeah.
Okay. So they use what's called the backpropagation reconstruction algorithm, which is highlighted here.
Yep.
So basically, when they use the algorithm once already inside the skin, and you have needle movement caused by the skin surface, which you will always have because some sort of variation based on resistance from the body. So even though the tip localization is very accurate, in order for the system to perform the backpropagation approach, so that the user or the doctor doing the handling of the robot, then the image gets distorted a little bit because of that error. So at the end, they highlighted the opportunity to use more sensitive encoders, so that any movement or deviation from the original path should be captured, and therefore the image reconstruction can be more of higher resolution. So there's a couple of examples here. As you can see, using the ultrasound, how the different trials they run looked at, and how they were able to align the path here, the red line, to the I would say to the way in which the vertebrae could be accessed through, so that they could extract the cerebrospinal fluids they're looking for. So at the end, it's kind of a it, it, they have validated a very good approach, which um, is novel in regards to the way it is done today with other processes that are not as innovative as this one, because here they have created um, a needle-shaped type of encoder, which is what
Yep.
they are actually using as a needle. Here you will see it. So that encoder is at the tip of the needle. So that's how they are able to, using ultrasound, how they are able to identify collision paths, and then because this is a 1 degree of freedom robot, they can still like shift angles so that they avoid any bones or blood vessels and all of that. So again, I think this is proof that that it works, and apparently the next step for this would be to acquire higher end type of hardware so that the image resolutions and technological system is more sensitive and therefore better imaging, etc. So the way they run the testing was they use some wires uh, which simulate blood vessels and bones. And also here on this image on the right, they use also uh, um, like vertebrate type material, and all the testing they did underwater to get like kind of the same resistance you will get, or similar resistance you will get inside of the body. Um,
Yep.
so yeah, a lot of algorithms, mostly image recognition, and of course you are creating an image with an ultrasound encoder. So most of these in I would say uh, new system is it works through algorithms. So basically, when highlighting the main objective of the assignment, which is the significance and innovation. Um, so I'm gonna read through it. So based on what
I
we could find throughout um, the entire paper as to what makes it what makes it significant in regards to the invention. So um, so they have proven a new method of doing minimal invasive um, lumbar puncture um, through simulation and a new framework which replaces previous manual frameworks they use today. And also today they also use another type of when they are looking to extract cerebrospinal body fluid, they use also another method which is let me look for it real quick. I can find it. But if they today they also use another type of method which uses radiation, like a CT scan type of method to do so, to map the whole interior of the body so that they can do the surgery. So those methods cannot be used on pregnant women or on people that have some sort of conditions that cannot go through radiation processes. Um, So in this case, they are they are improving the current methods using a new one that is not harmful for the body, and they have also like been very ingenious on running some simulations like what I said about using the wires as bones and vessels, and um, and the spinal cord, etc. Um, so they are highlighting the new approach as eliminating a lot of accuracy problems the current more manual methods have. So a lot of automation is also there. Also, they highlight the need of real-time data um, during the insertion period, which is something that they don't have today. So they will be able to alter the insertion path so that again you don't hit or damage any blood vessels or hit any bones, etc. That can make the process take longer or more harmful to the person. And again, no real-time imaging exists today for this. Everything is made kind of external to the body, and then it's just a one try. It contains a lot of guessing. So here, because you're doing it real time, once the needle is in, there's not a lot of guessing. It's exactly what you have in front, and you can alter your path using that information. And another other type of method has been tried regarding this particular so lumbar puncture process, but all of the other methods use a lot of different like hardware, different systems. And from the book, from the paper, it highlights it as something the medical clinics are not into, because again it's a lot of money for them and a lot of different systems that you need to get training on and all of that, and you can make a lot of mistakes by having a lot of systems. So here is just one very simple automated way of doing so. And then in regards to the innovation, so this is the first attempt to using a needle-shaped
transducer, ultrasonic
transducer, correct. So, which is that by itself, that modification of a component to use it as a needle is kind of very innovative. So again, 1 degree of freedom, 1 degree of freedom rotation used to be able to alter the insertion path. And yeah, it bases this new approach as the first attempt to do something, which is one of the things Dr. Hata highlights as very important for innovation. So part of the validation, they also use an Arduino processor to run some of these testing. So a lot of integration were performed here. So they kind of, on these charts, what they collected throughout the entire simulation, so they had like multiple targets they wanted to go and see if it was capable of doing the real-time imaging. So here you can see the actual measured distance based on the transducer, and the actual distance based on the simulation on where you thought it will end. So you have kind of a simulation versus the real life distance for the test or the location of the tip. And also it highlights kind of the I would say the relative angles of the 1 degree of freedom robot that it has to do in order to go straight to where it's supposed to. Again, the encoder versus the simulation numbers are very, very similar. And at the end, so they highlight the different type of errors that they encounter during the insertion. So of course they have the actual tracking error, which is where is the tip of the of the needle.
Neither.
The rotational tracking error, which is through the encoder uh, of the of the joint, and then the actual motion, which is the forward motion of the needle. So those three errors are measured based on where it was supposed to be and where it ended up being because of the resistance of the body fluid, which basically um, it is what they at the end they proposed that uh, they needed higher resolution of detection to be able to meet a more accurate path and behavior of the tip of the needle. Um, so like I mentioned before, so although the simulations were completed and the clinical feasibility is kind of is evident because all you need, they highlighted that all they need to do right now is using more sophisticated technology to run the same method, the same test. So I guess that will be the next step for this particular invention. And again, they have a very novel medical workflow with high potential on other procedures, especially for they highlighted the obese. When obese people, on some cases, it's very difficult to be precise and be able to target to the spinal cord, or and there's a very low yield. Like I remember, it's about 80% of the cases are only successful. So imagine, so 20 some of the surgeries are not good for this particular approach they're looking to replace. So again, out of 120 some will always fail. So that is very in order, if we use this and we are able to tackle that and make it 99 or higher, that would be a very groundbreaking type of procedure for the medical world. So any questions?
Yes, I think you presented you presented the paper very well, and you spoke about the methodology, you spoke about the significance and the innovation in it. So I do agree with you that the needle transducer, needle-shaped transducer, and putting the transducer in the same location of the end effector and making it a needle is a very new concept, or it's an innovative idea. So I think on innovation, they're doing really good. I do have a few questions on the significance part of it. So the first one is, with doing real-time data imaging, what is the time of the procedure in real life compared to older procedures that are done blindly while hitting in the blood vessels? And then the other thing is, because at the beginning of the paper, it said that the current procedure is basically you're choosing the spot and you're going with the needle in straight line and you hit into some blood vessels. There is some sort of a blind approach where you just go into your final location, take the sample and come back out. The next question on significance is, what is the value to the patient? I mean, maybe it's just very small blood vessels that they hit in the normal one and it still works, or is it like saving a lot of complications? This part I was not sure of. The other thing that I had on it, it did concern me, the 1 degree of freedom, because what if 1 degree of freedom is not enough to be able to avoid obstacles?
Yeah, I think they highlight that as to So the other variability the system has is that, for example, if if there's any movement to the base of the actual 1 degree of freedom robot, then the imaging that you will do that you will get back from the tip will not be accurate. So to your point, I think that is a very good concern, because I believe that um, for future modifications to this approach, they might come up with a different base for the actual system, so that they reduce the amount of error induced uh, by let's say you're using a needle system which is, let's say, on a table, where your patient is in a bed, for example. So any movement of the patient at all will offset also the needle direction. So I guess to your point, it will be good to see in the future something like uh, something that detects the movement based on where the tip is at. So with an additional degree of freedom, you might be able to compensate for that offset of movement of the body, so that you never like I would say, so that you maintain that straight line and the path that you like. So yeah, I believe that that will be kind of a second step for this paper, Rami. Good catch.
Yeah, that's all I had on it. I just wanted to make sure we are referring back to evaluating the paper based on significance and innovation, and that's why I tried to break it down like this, so, and analyze each one in terms of the paper.
Yeah, so I would say that it highlights that more than 400,000 LP procedures, or lumbar puncture procedures, are performed per year, and 77% is the success rate, which means that there's a lot of complications, a lot of more. So this is minimal, a minimal. Is it, what is the name?
Minimal invasive procedure.
Correct, correct. So a major invasive would be kind of a surgery already, so that the patients will take longer to be able to recuperate,
Yeah.
and yeah, more painful. And I believe that the whole medical world is moving to uh, doing more with less or minimally um, surgical procedures.
And then the other thing that it showed, when we were speaking about the ultrasound transducer, and it showed the range of motion and the range of the transducer, it's just showing it in 2D now. Does the transducer rotate 360 degrees, so it captures that whole view?
So there's no need. They don't mention it as it could go up or so. I imagine it can. However, the way it is handled is right now, it's gotta go above the person. So it would always look down. So you don't have no need to do a 270 degrees or so. It will always fall within the same range. Um,
Okay.
yeah, so that's what I said, that probably another degree of freedom will be able to cover for the base positioning. So it will be a more automated system, I believe. Uh,
Okay.
but but again, they were focusing more on image reconstruction uh, based on what they can read out of the transducer of the tip of the needle, and the
Okay.
communication and the communication back to the tracking mechanisms and encoders.
Yep.
So that was basically the main validation
Concept.
they were conducting here.
Yeah. No, that's good. Thank you for sharing, Alfredo. I think that was a good paper and a very good discussion. So
Thank you, Rami.
So can we go to my paper then now?
Yes, sir.
Okay. So I'll bring it here and then we can share after that. I can share my screen here. All right, so let me share my screen here. So can you see my screen?
Yes, I can.
So the title of the paper is Through the Eustachian Tube and Beyond the New Miniature Robotic Endoscope to See into the Middle Ear. So basically, this is the synopsis, my synopsis on it. So we'll start with the background and speaking about the background for this study or why it was done is that one of the directions in the medical robotic field is to try to use as many like natural orifices in the body as much as possible. So the middle ear, the middle ear is beyond or underneath the drum, and behind that drum there could be some fluid or some sort of a tumor or something, and sometimes it can go a long time undetected until it eats into the eardrum, and basically it results into significant hearing loss. And the basis for a good diagnosis is vision. The doctor needs to be able to see what's inside there and be able to visually see it so that they can make a proper decision on the diagnosis and the treatment. Right now, if they go through the Eustachian tube is basically, from the nasal opening that goes to the middle ear. And due to the anatomy of the body, the nasal opening and the location of the middle ear are not 100% aligned. They are on different planes. So whatever has to go in there has to make a bend in order to get to the middle ear. So right now, all they have is a straight endoscope. And there has been studies that were made, and it was found that with a straight endoscope, that only 6.9% of the cases, if they put a camera on a straight endoscope and they go in there, in 6.9% only of the cases, they can visualize the area beyond the middle ear. Other than that, it's not successful. So the alternative is that they go through the auditory canal, which is the ear opening, and then they actually lift the eardrum or cut the eardrum, and then they are able to see into that area very clearly. So that is basically surgery. So the objective of this paper, the goal of this paper is to develop and validate a wire-driven wrist motion robot with a high resolution camera mounted on the end effector. The intent of that robot is to be successfully used to visualize the sinus tympani region, which is the region behind the middle ear, through the Eustachian tube. And this way, you do not have to do surgery anymore and lift that eardrum through the auditory canal, but you go from the other side. So the robot The significance. The robot that authors present may improve and expand the repertoire of techniques available to doctors to use a natural orifice instead of surgery to conduct visual diagnosis and to improve visibility in the sinus tympani region. The innovation the robot presented in this article, if successful, is the first attempt to use a robot through the eustachian tube. So basically, the innovation of this is that it has never been tried. That opening has not been used before to insert a robot or a inside there for that operation. So when we go and speak about the methods, we'll break the methods into two sections. The first section is accurate modeling of the middle ear. And then the second is the actually three sections: kinematic modeling of the robot and construction of the prototype. And then the third section of the methodology is conducting bench validation experiments to validate the accuracy of paths generated by the robot. So for the first section, modeling of the middle eardrums, so they took 6 patients and they did CT scans of the 6 patients' ear anatomy, and they modeled the angles and the distance between the eustachian tube and the middle ear sinus tympani region on those 6 patients. And based on those modeling, they were able to identify what range of motion that miniature robot needs to have in order to cover for those 6 patients. And then basically based on that, they found that that robot needs to have to be able to bend up to 74.6 degrees. So that is the range of motion on the rotational side, that it needs to bend up to 74.6 degrees. And then after they did this, then they created the kinematic model of robot and constructing the prototype. So, no, sorry, I missed something. So in that first section, after they found what the kinematic, what the ranges of angles the robot need to have, the next step they did is they used one of those 6 models and they created a phantom prototype with something called stereographic 3D printing, basically, which they used to be able to create a phantom model of the middle ear, and then basically they are going to insert that robot in it. So the next step or the next section is constructing the robot. And when we look at the construction, there are several phases in it. First is the concept itself, and then after this is actually making it. So the concept itself is basically, it has a rotational, so it can rotate, it can bend basically, and then it also can advance forward, and then it can rotate all around itself. So it has 3 degrees of freedom, 2 rotational and 1 prismatic. When we look at the bending of it here, the relationship is just a geometric relationship that was established between the amount of pull and the angle generated. So that is the relationship that kinematically we have to be able to establish, and using geometry, they were able to establish that relationship between theta, which is the bend angle, and the amount of pull required. And so after that was done, then they started to actually make the robot. And so the robot, as you can see here, the 3 degrees of freedom I've been speaking about, the theta of the bend and the phi of the total rotation all around, and then the z is the prismatic. and it's made of a certain plastic material made using CNC equipment, and its overall outer diameter was 1.8 millimeters and its inner diameter is 1.6 millimeters, because it has to be less than 2 millimeters in order to fit in the eustachian tube. And then a high resolution camera was connected on the tip of the robot, and an actuation tendon is used for steering the tip. So that actuation tendon, basically, it pulls, as it pulls, it bends, and as it releases, it straightens back up. So once the prototype was made, then they start in the validation. So the first step in validation, before they actually did anything with inserting that robot inside of the model, the phantom model created, the first step is they did calibration. So on the calibration, it showed, and I can pull the graph from the paper here just for reference to show you the calibration results from the original paper. So here the calibration results are showing that as you have a displacement of the tendon, so the tendon is pulled 1 millimeter, then the bending angle is almost 20 degrees. 2 millimeters, it's 40 degrees. So there is a linear relationship between the amount of displacement of the tendon and the bending angle of the robot, which means that that system is working in the elastic range all up to 160 millimeters, and which equates to 6 millimeters of displacement. And it only needs 74.8. So that means that it's capable to work repeatably in the elastic range all through its operation range that's required. So it was very important to do the calibration for that. Once the calibration is completed, the next step is that they did the phantom experiment. As the robot was inserted in the phantom prototype of the middle ear, both position and orientation of the tip were recorded, which were used to calculate the viewing surface of the sympus tympani region, as the camera specification to be used with the robot has a viewing angle of 90 degrees. So they used all the geometry of the camera and everything to calculate, based on the orientation of the tip and location, how much viewing surface is going to be seen. And based on that, the results of the phantom experiment showed a visual coverage of 74.1% compared to the original 6.9% achieved by a non-flexible. Further studies showed that approximately 94% of sample population for 296 people had ear geometries that would be easily navigated through by the proposed design. So basically, with the design seems to be, from an initial perspective, successful. The paper presented the use of a robotic endoscope that is bendable, and it has the ability to go in the required area of the middle ear without any surgery and offer good visualization to the doctor. Now, the things that do concern me about the study, when I want to evaluate it, when I look at the innovation, I think it is an innovative paper, definitely, because it's using an orifice or an opening that has not been used before. And significant, yes, I think it has a very good significance because it's basically avoiding surgery and all the complications that go with surgery. However, there are some concerns I have. The concerns I have is that they used only 6 CT scan ears. How do they know if that is going to fit into the hundreds and hundreds of people and is going to work? And the other concern that I have is what if there are restrictions in the station tube that would not allow this thing to go in? Then what would be, what will be the, I think there needs to be more data collection, more scans made for it to be successful. But I think the paper has very good potential. So that's my
Yeah.
presentation on that.
Yeah, I believe it is very good job, Rami, explaining this. I couldn't even needed to see it, but you explaining it make it very easy. So I would say I have a couple of questions. So basically, based on the graph that you showed, that robot can go like twice the rotation amount that was needed for to be able to map the entire back portion of the ear. So you mentioned at some point that it was 74 or some
Yep.
degree that you were looking for, but you basically they fulfilled that and exceeded it by almost 200%. So I believe that adds a little bit more flexibility um, into mapping probably additional internal locations that the paper is probably not highlighting at this step. Um, so my concern would be kind of a similar to the one that I showed. If how steady should the person be so that there's no collision, because you're going through very sensitive areas that a little touch could mean like a bruise or something. Um, so I'm just concerned about what methods they use and how well does this robot can react to the body movement. So like normal heartbeats which vibrate and cause any type of movement or stuff like that.
I think these are very valid questions, and my attempt to answer these will be twofold. First is by looking at the design of the robot itself. So it is made of nitinol tube, and as you can see here, I'm showing the picture of the tube itself. It doesn't look like it have any sharp edges that could cause some hurt. So hopefully it is all rounded off and all very smooth, so it doesn't cause any puncture in the station tube where it's going through. The other thing is that its OD is 1.8 millimeters and the station tube inner diameter is 2 millimeters. So there is a little bit of room just in case for some motion. Now, the other thing that I don't know is I don't know if when they're doing this, maybe they're sedating the patient. So maybe the patient is under anesthesia or something, so they're not moving, but that part I'm not sure of.
Yeah, probably they I believe they need to be.
Yeah, but this here is just at the engineering level. It's not, I don't think this paper just discusses that through the phantom experimentation and nothing through the human body yet.
So that will be, you see that as a next step for this?
Yeah, absolutely. Think so.
Very good. So yeah, I mean, not having to do surgery and going through a very controllable, this is a continuum robot, right? It's just like the one that we're reviewing for the class, the snake robot. So I see there's a lot of different applications for this.
Yep.
And again, the medical industry is moving to eliminating and not having to do surgery. I would say that is basically the common characteristics of most of the inventions that we have been working with.
Yeah.
So I agree with you regarding the sample size for CT scan. I don't know how much variation every human may have in regards to the size of the apertures, etc.
Yeah.
So yeah, I believe probably once they, before starting with using real human testing, etc., they should, I guess, increase the amount of sampling, and I believe that should be a requirement. I don't know if the FDA regulates this industry or who, but definitely it should be kind of something required prior to starting any human testing, right? Any application itself.
Yeah.
And so yeah, and again, you highlighted the so the true need is to go and see stuff that is usually hidden. Um, so I'm very interested in seeing um, what clinical data they get from patients going forward to um, like if this procedure gonna be performed for any type of common flu, etc. What benefit would you get out of this if you would do it? Um, like, can you do better? Um, can you do better? How do you call it? Like reviews, um, and therefore provide a better path forward for people to be better sooner, like uh, recommending different medicines, etc. Because you have more information.
Yes.
I don't know. I guess I'm going a little bit off, but the different applications you could use this to collect more data and then use that data to come up with different newer alternatives. I believe that is very interesting.
Yep. Yep. Okay. So that's good. If you have any other questions, or with that, we
No,
conclude the
yes, sir.
synopsis study. Yes.
I'm gonna stop recording.
Okay.